Introduced you already. I don't know if you heard me.
Very good.
Was he? So you should have the ability to share.
Okay, great.
Um, if you
Excellent.
don't, I will do. There, I made you
Let's start
co-host
there.
just to make sure,
Yep.
and I will mute myself. Thank you again for your time. We're always so grateful for your time, Dr. Elke.
Thank you. It is an absolute pleasure, as always, to be with the Geriatric Fellows group today. And as Dr. Reinhardt mentioned, I'm going to be talking today about the health policy landscape when it comes to geriatrics and late life care, where we, have policy infrastructure in place, as well as where there is a need, indeed there is space for additional work and really additional policy reform. So without further ado, again, as mentioned, I am Daniel Elke. I'm at the Department of Health Policy and Management within our Downstate School of Public Health, coming to you today from my beautiful home in Ossining, New York. And again, in about a half hour, I'm going to have to take a brief break. When I notice the school bus in the corner of my eye, I'm going to make a quick break for it. I'll be right back on, I promise. Just have to get my son through the door, get him his snack, and get him ready to go. So that will give you some time to ponder and reflect, perhaps, and come up with any questions you might have. So we can kind of take it as an opportunity, if you will. So without further ado, let me begin. Let's face, to start off with, some of the figurative elephants in the policy room. And by elephants, obviously not talking about literal elephants. I'm not even talking about Republican elephants, although party politics will be coming into play, as you will see. So I want to get started by talking a bit about some of the basic, again, policy building blocks when it comes to coverage for America's seniors and those entering the final stages of life. Some of this will be a review, most likely for many of you, but hopefully I can add a twist here or there that will enhance it a tad. So to start off with, I think we're all familiar with Medicare and Medicaid writ large. But when we talk about both these programs, it's vitally important to really break them down into their constituent parts and to get a sense of really what's inside, what those moving parts look like. That's particularly the case when it comes to Medicare. Of course, Medicare is comprised of several different parts, as they are known. We are now up to 4 parts, to be exact. We may add more in future, but that's what we're currently up to. So Part A is the part of Medicare that perhaps the greatest number of people are familiar with, and that is the original core of Medicare. Part A is a compulsory contributory program that largely covers hospital and largely covers acute care. And as you know, is implied by the term compulsory, everyone is pretty much automatically made a member of Medicare. You start paying into it, obviously quite early in life. We all can see out of our paycheck where Medicare payments are taken out. This is where they are going. Largely to this Part A program. And again, most everyone contributes to Medicare, Part A particularly. Now, Part A was constructed in this way very deliberately. There's a reason it looks this way. And that is because when it was being designed in the middle part of the 20th century, health reformers were very concerned that they shake off the suspicions that surrounded anything that had even a vague whiff of socialized medicine. And the way to do that, the way best to do that really, was to model Medicare, this new Medicare program, off of what was at that time becoming a very popular program, and that is Social Security. So Social Security had been around by the late 1950s and the 1960s for about 30 years, had quickly gained in popularity, that public pension for retirees, paid for out of a trust fund that everyone contributes to. And so this was an incredibly popular program. And so the best way to get Medicare passed was effectively to make it in the image of Social Security and to pass it that way. So it is perfectly modeled after Social Security that had come 3 decades before, and again, quite deliberately. But that's not all there is when it comes to Medicare. Of course, we have our 3 other parts. Part B generally covers doctor's visits and much in the way of preventive care. So care provided generally outside of the venue of hospitals. And it is a voluntary program. You may in fact opt out, though relatively few people do. So it is not compulsory. So Part B looks different already right off the bat. Not only does it cover different things, but it's also different in terms of its basic program design. It is not compulsory. Medicare Part C and D came quite a bit later compared to these 2 original parts. Okay, so Part A and B came around in 1965. They were signed. We're going to see a picture actually of the signing ceremony in a moment. And I'll let you in on some of the history that was involved there. But Part C didn't really come around, wasn't firmed up until the mid 1990s or thereabouts. So it's now been with us, 20, 25 years. And Medicare Part D is even newer. It did not come around until 2003 under what was known as the Medicare Modernization Act. So what is Part C? Part C, you may not know it as Part C. You may in fact know it as Medicare Advantage. So Medicare Advantage is the part of the Medicare program that is still financed through federal funding. So the federal government is still financing medical bills, but they are effectively being channeled through private insurers. So that is Medicare Advantage. And you may wonder, well, what is the advantage? In this case, well, Medicare Advantage plans tend to cover more than so-called traditional Medicare does. So it has extras added in. Those extras could include vision coverage, dental coverage, for instance, other areas that are in fact gaps within the original Medicare program. Now, this does come with premiums that you pay in. And in fact, the federal government pays Medicare Advantage plans even today at slightly higher rates than they do the same group of people within traditional Medicare. So again, this has been around since about the mid 1990s. It was an attempt really to bring the private market into Medicare. And it's actually been somewhat successful in that regard because at latest count, a bit over a third of Medicare beneficiaries receive their coverage through a Medicare Advantage plan. And that number seems to be steadily rising. So it has gained in popularity. And what's fascinating from kind of a political standpoint, as opposed to a policy standpoint, but a political standpoint, is that Medicare Advantage began as very much a solidly Republican proposal, with quite a bit of skepticism on the part of many Democrats, as you might imagine. But over the years, over the last 20 some years, it has gained in popularity so much that Democrats now find it difficult to avoid it. And they have perhaps reluctantly come to support the program as well. So it now attracts bipartisan support. That was not the case when it first came online in the mid 1990s. So finally, we come to Medicare Part D. There's a nice little mnemonic, I like to think, that comes with Part D. The Part D stands for drugs, prescription drugs in this case. So Medicare Part D came along, as I said, in 2003 as a result of the Medicare Modernization Act. It was, at the time, the first significant expansion in Medicare since the program was passed back in the mid-1960s. So we went nearly 40 years before Medicare was significantly expanded. Now, that's not to say that there weren't smaller expansions in previous years. So one of the most significant of those was perhaps the expansion to those with end-stage renal disease that occurred in the early 1970s. But even that, again, only occurred about 6 years after the establishment of Medicare. We went over 30 years in which there really wasn't any significant expansion of Medicare, despite the goals and what was envisioned by the program's original framers. Finally, our final policy building block here when it comes to care for seniors is, of course, Medicaid. Medicaid is a major player, sometimes overlooked in terms of the huge policy footprint it has when it comes to senior care. And the reason it plays such a vital role is that, again, there are significant gaps in the original Medicare program. Perhaps the most significant of those gaps is long-term nursing care. Medicare, for the most part, and there are some exceptions, but for the most part was not designed to cover long-term nursing care. So in fact, many people have to look to Medicaid in order to finance long-term nursing care. And as many of you are probably familiar with, this often entails a significant drawdown in funds, in earnings, in order to become eligible for the program over time. And we'll talk a little bit more about that in a bit. So I promised that I would have a picture from the signing ceremony of Medicare. This is it. Does anyone know, I'm going to ask for a little audience participation here. Does anyone know who the gentleman on the right holding all those pens happens to be? Any guesses?
Truman.
That's right. Exactly right. Very good. I knew you'd get it. Very good. So there's a reason that Harry S. Truman is present, the guest of President Johnson, shown at the left here. Again, this is the occasion of the signing of Medicare and Medicaid, signed as amendments to the Social Security Act in 1965. And the reason that Harry S. Truman is present is that Truman had been part of the ongoing political battle for universal health insurance, actually going back to his time in the White House at the tail end of the 1940s. He was the first president to champion in any significant way universal health coverage. And the plan he had in mind actually mirrored that of Germany, in that you would have very heavily regulated, largely private insurance companies, with the federal government covering portions of the population that were not covered by private insurers. So it was not socialized medicine by any stretch of the imagination, but that boogeyman, if you will, very much appeared in the debate over his national health insurance plan during the 1940s. It got bound up in Cold War politics. So opponents claimed that it was a Soviet plot. And it also got bound up when it came to race politics as well. Because one of the greatest fears of particularly Southern Democrats at this time, from the 1940s through the 1960s, was that any national health insurance, any national program like this would come with a directive that would lead to the desegregation of Southern hospital facilities. And in fact, under Medicare, that is exactly what happened. There's a brand new, fairly new now, book out on that topic about how the signing of Medicare became a vehicle effectively for the widespread desegregation of hospitals in the South. So this debate over national health insurance got bound up in Cold War politics and race politics. And both those major conflicts, those defining conflicts, are one of the reasons why, arguably, we have never gotten to universal coverage It's been a much narrower journey, as we'll see. So Harry S. Truman, the first president to champion universal coverage, and when President Johnson signed Medicare and Medicaid into law in 1965, he invited the Trumans to the ceremony, and President Truman was made Medicare beneficiary number 1. His wife was Medicare beneficiary number 2. So that is the signing of Medicare. What's important to note about this, though, this period as well, is that originally Medicare Part A, Medicare Part B, and Medicaid were 3 different pieces of legislation that were championed by different constituencies. So Medicare Part A was the original progressive program designed to cover mainly seniors. Part B originally was it's a voluntary program. And it was one of the somewhat more conservative alternatives that was presented, largely by Republicans and conservative Democrats. And finally, Medicaid was a third alternative. And it drew on a previous program that had actually already been in place. And that was a program that basically directed grants to states in order to ensure that those who were poorer within those states could receive coverage. And so these are 3 different programs. Medicare Part A is the original progressive core program. Medicare Part B and Medicaid were more conservative alternatives that President Johnson tacked together, added them all together to get them passed as a single package in 1965. It was actually an act of what I consider to be political genius, in that it allowed Johnson to share credit with those who would have otherwise opposed him. So again, as I've said, Medicare was a part of what appeared to be a path to more universal coverage. This had been a battle that had been waged all the way from the 1910s through the 40s and indeed beyond. Initially, the drive was for universal coverage nationally. That would be at least partially financed through the federal government. However, time and time again, due to opposition from various quarters, including, again, as I've mentioned, Southern Democrats, for reasons of race politics, but also organized medicine. So the AMA, one of the stoutest opponents of universal coverage. So elements of organized medicine as well, small business groups, and indeed large business groups, the Chamber of Commerce, groups like that, also opposed. So on repeated occasions, the apparent drive toward universal coverage was turned back. And as a result, these reformers who had been battle tested again and again finally decided to, rather than try to cover everyone, narrow the scope of their drive for coverage to those that most people could view as being broadly deserving. And that at the time was seniors for the most part, who were left outside of the private employer-based system for the most part. Now, early framers, early Medicare boosters, as I say on this slide, made it pretty plain that, yes, they were starting narrow, they narrowed their scope, but they were looking to expand it. So they, over time, envisioned simply lowering the eligibility age over periods of time and getting to universal coverage that way. They were quite candid about it. However, for a variety of reasons, including a souring economic climate, and a more conservative political era starting in the early 1970s. That did not come to pass. And so instead, as I've said, we had a situation where the Medicare program and to a large extent Medicaid sort of became frozen in time. You don't see significant expansions really of either program for the most part until, again, you look toward the 1990s, beginning with the Children's Health Insurance Program, and especially with the Medicare drug benefit in 2003. But again, you go a whole 30, 40 years in which there are not significant expansions that are passed, despite, again, the aim of those who were supporting the program at the start. So I mentioned that long-term nursing care does not, for the most part, fall under Medicare. I'm sorry, you'll see me glancing out the window to make sure I don't see the school bus coming. Again, not covered under Medicare. However, there are some that could consider to be exceptions. So there is coverage under Medicare for some long-term care that can be seen to be going toward the decline, arresting the decline, excuse me, of a terminal condition. And Medicare does cover much in the way of hospice care. But outside of those specific examples, for the most part, Medicare was not designed to cover long-term nursing care. And this is something that, for those outside of medicine, for those outside of health policy, this is something that catches many people by surprise. And that I think it is incumbent upon us to make sure that as much as we can, we get the information out there when it comes to what Medicare does not cover and what Medicaid does cover. So outside of long-term nursing, even Medicare still doesn't cover everything or nearly everything. There are huge gaps. There is a reason that there is an entire class it's huge be covered under Medicare Advantage, for instance, but traditional Medicare, right? Dental care, eye exams, plastic surgery, and again, that biggie there, long-term nursing care, not covered under Medicare. So that means that many seniors must fall back on Medicaid, and many, in fact, do. And it's fascinating to me, therefore, this headline statistic here that if we take them together, seniors and people with disabilities account for only 24% of overall Medicaid enrollment, but a full 63% of the spending. And if we just take seniors into this equation, you can see it's 9% of enrollees, overall enrollees. So a rather fairly small proportion. But that adds up to those 9% translate to 21% of the overall expenditures. And again, the overall expenditures for the program around 400 billion, at least as of 2011. It's probably significantly higher now. I should probably update that slide, in fact. So this creates, of course, a very difficult situation for many individuals and many families, a situation that requires a significant amount of coordination and coordinated action at times, long before one approaches a point where one needs long-term nursing care or assisted care. So, some, of course, are going to be eligible for Medicaid immediately on the basis of lower income. Retirees particularly. However, others must spend down assets to become eligible once nursing care is required. And there are maximums to the amount that can be held in order to remain eligible, either as a single individual or a married part of a married couple. And if, again, you try this to spend down or to transfer assets within 5 years, of reaching that point, there's a look back period that means that people can incur penalties, as many of you are probably aware. And so again, it creates a very perverse sort of policy environment and a very difficult situation that requires quite a bit of planning for many individuals and families when we're talking about ensuring eligibility for Medicaid. And for many, again, we're talking about that because many people find it exceedingly difficult, of course, to finance long-term care, particularly out of pocket. This is something that is out of the capability of most. That remains the case. However, this also means, that there are significant gaps when it comes to, the caregivers that may be available. many people must turn to family members. And this cost is not effectively taken into account when we think about our overall economy. And as part of the COVID-19 pandemic, many of us are becoming quite aware of the cost of care that is provided by family members and largely uncompensated, again, particularly when it comes to women, of course. So if we look at the economic impact of caregiving, it is thought that these free services, which of course are not free at all, come to around $306 billion, a very large figure. Of course, I said, women are disproportionately affected. Women average 11.5 years out of the paid labor force because of caregiving responsibilities. And American businesses lose between 11 and $29 billion due to the need to care for loved ones. And now, obviously, for 50, and these are for loved ones 50 years and older alone. So we're not simply talking about parents, those caring for children, but we are, in fact, in many cases, talking about those who are caring for older family members. And again, the fact that it falls onto families is partly a result of the insufficient policy infrastructure that we have in place to ensure quality care for older Americans. Fortunately, outside of the rather sparse federal arrangements that are in place, there are some stopgaps that are in place at the state level here in New York State. Now, this is just in New York State. This is not necessarily the case in many other states across the country. So there are several programs, or twinned programs in this case. The Expanded In-Home Services for the Elderly program, which funds care in the home, and thereby avoids more expensive, both to individuals and to the state, Medicaid-funded institutionalization. And again, in recent years, this has been paired with another program, the Consumer-Directed Personal Assistance Program, which allows for the training and funding of family members to assist with care. So it begins to take on this problem of care that in many cases is uncompensated and allows it to be compensated. However, again, this went into place in 2011, so it's a fairly new series of programs. Recently, just on the eve, actually, of the COVID-19 pandemic, the first wave here in New York, some of you may have heard of the Medicaid Redesign Team, or MRT2, that was convened. Basically a team that the governor put together to try to squeeze savings out of the Medicaid program. Governor Cuomo faced budget shortfalls and decide to target Medicaid for cuts, try to find savings there. So some of the areas that were targeted included long-term care plans and the aforementioned Consumer-Directed Personal Assistance Program for what could potentially be massive cuts. Now, COVID-19 pandemic kicked in, again, this occurred days before the lockdowns went into place, in mid-March. And under the terms of further federal assistance that came into play with the pandemic, one of the conditions was that there could not be significant revisions effectively to the Medicaid program. And so Cuomo and his administration were effectively required to shelve some of the massive cuts that they had envisioned if they were going to receive the further federal funding. So as of this moment, those cuts appear to still be on hold, but we don't know how long that reprieve effectively is going to last, whether it's going to carry over into next year or the years to come. So again, pandemic occurred, and there was a bit of a reprieve when it came to cuts to these programs, but how long that reprieve lasts is anyone's guess, really, at the end of the day. So I've actually, no, I ran through that very quickly, I guess. So I am happy to take any questions or comments you may have. I don't know if I was anticipating the school bus or what, but I went through like the Micro Machines guy. I don't know. I'm dating myself by referencing the Micro Machines guy, but you know them anyway. So yeah, so I'm happy to take any questions or comments. And we can talk about, for instance, ways that we might reform this rather threadbare policy infrastructure that is currently in place. So, and with the caveat that I will have to run off and get my son off the bus shortly, but I will come back, I promise.
Hi, this is Shirley Gerard. Thank you for that history. I'm wondering if you might talk about some of the current legislation, some of the modifications that have been done vis-a-vis COVID-19, and a couple of things I know about are in relation to what gets paid for and who gets paid for doing it, and that includes issues like telehealth and the use of other providers.
Absolutely. Thank you, Shirley. That's a great question. I'm glad you brought that up. Yeah, so, I want to start by saying that, when the ACA came around, there was, of course, a real missed opportunity there when it comes to, what gets compensated, of course. And I think you probably detect what I have in mind, and that is the so-called death panel debate. It's now hard to kind of go back to that period and what that entailed. But, and excuse me, I'm going to have to rush off for a second. I will be right back. Just a moment.
Dr. Reinhardt, do you want to continue the conversation or ask if anyone has some questions? Maybe we can jot them down in the chat.
Yeah, I think we could
Yeah, we could
bring up further
just-
questions, or
Yeah.
Shirley is also, Dr. Gerard is also a healthcare policy expert and former legislator. Did you have additional comments that you wanted to run through while Dr. Elke is away?
No, I was just thinking that we could just utilize this time.
Yeah, I guess I was asking Shirley. It sounded like she had something very particular in
I
mind.
think the whole
Is this happening just for me, or is this happening for everybody? Okay.
For everybody, and my Wi-Fi is also hinky.
Dr. Gerard, if you can hear me, you're pretty frozen.
Yeah, I think the whole issue of what's that? Oh, it says my internet is unstable.
You're back. You're looking stable again.
I was just going to say that whether you're in primary care or psychiatry, or your future is as a direct healthcare provider, or even if it's as a manager or a public health person, it's very interesting to know that the whole telehealth, telephonic approach to care is something that was not widely accepted by Medicare or Medicaid, more by Medicaid actually than Medicare, until this pandemic hit. And there's great debate going on at both the state and the federal level about how that will continue and what it's going to look like and what's going to be reimbursed. So so I think that's something for all of us to be aware of, because it's, you only do what you get paid for. And there's some interesting work going on right now in relation to payment, specifically around Medicare and Medicaid, that relates to payment for value, which really is about cost. And I serve on the Practice Transformation Task Force in Connecticut. And they call it, I forget what it's called now, but it's about changing. It's supposed to be about the way we change practice, but it's really about the way we allocate resources, i.e. money. And they're thinking about putting caps, increased caps on healthcare spending. And so I asked the question, well, how are we going to do that? Because it's all done based, all of the payments are, and I won't say 100%, but a huge amount of the decision about how much gets paid for what is related to actuarial data. That's how the decision gets made. And so that means it's based on existing data. And we know that practice and people's access and use of services changed dramatically during COVID. And so doing benchmarking for price or cost is really an issue. So these are issues as healthcare providers you want to be sure you stay aware of. And get involved with your legislators and influencing your legislators, because they will listen, those who vote on public policy will listen to providers, because as voters, you are the largest, we are the largest voting bloc. So even though we know that lobbyists and special interests have make a big difference, and many of our professional organizations are in the forefront of helping to advocate for the right thing. But it really is an opportunity for all of us to be engaged in that work and to sort of stay on top of it and speak out. I'm
sorry, go ahead, please.
Yeah, the other thing about policy, I think that's been brought to the front, and as many people have said, it's not new, we're just paying attention to it. And that are the disparities, the racial and ethnic disparities that exist. We've always known about them, but they have really, they've sort of been front page for months now. Will that change the way we do policy will be the interesting question.
Absolutely. I think both of those points are absolutely spot on. And the ACA really, got the ball rolling on this idea of really putting the squeeze on Medicare funding. That it called for the establishment of the Center for Medicare Innovation, which sounds very positive, of course, on its own count, right? Looking for new ways to make Medicare function normally. But the goal was, again, to try to keep the squeeze on Medicare. And it also called for the establishment of this Independent Payment Advisory Board, or IPAB, which, if convened, would have been required to locate cuts. If, again, looking at those actuarial tables, if spending in a given year looked to significantly overshoot certain targets. Now, again, the IPAB faced a lot of opposition, and for years, no one was even impaneled to sit on it. It was supposed to be a 15-member body, and no one was was appointed to sit on the body. But again, it's opened up this whole debate about finding different ways to pay for care, whether payment for value, payment for outcomes under Medicare, and by extension, throughout the entire healthcare system. And, yes, a part of that is about delivering, I think, better care, but a larger part of it is about finding kind of these actuarial tricks to save money, right? To spend less money. Especially given, the overall aging of the population overall. I think that's what really was at the forefront of policymakers thinking. And yeah, when it comes to telehealth, I mean, the payments for telehealth were pioneering, under COVID, and an open question, I think, how much of that does remain permanent. My understanding is there's been a bit of an erosion of it already, but is that something that becomes a larger part of the way we deliver care both to seniors and really to all Americans? And does that also open up, further inequities, when it comes to, those who have the technology available, who have the technological acumen, really, and those who don't. So, there are some positives and some negatives there when it comes to, what we've discovered in terms of providing care via telehealth during the course of the pandemic.
Were there any other comments from our questions from our trainees and students?
The question from my son was whether he could watch My Little Pony, and the answer was yes, he could at this moment. So
Yes, absolutely. Or Paw Patrol. Paw Patrol.
yeah, there you go. There you go. We've been through the Paw Patrol era. Yep.
Or Thomas the Tank. Okay.
I have a question. I'm not sure if you
Yep.
guys can see me. My name is Sam Jackson. I'm
Hi,
a
Sam.
second year psych resident, interested in public psychiatry. Don't have much of a background in this type of stuff, so I really appreciate this lecture.
you.
I do have a question on relative value units and how RVUs are made, by whom, or decide the value of things, and how this sort of plays into our system, and what are some of the drawbacks of having that?
Yeah. So yeah, that's a great question. So the way we compensate, much in the way of care, particularly on when it comes to Medicare and other programs. Yeah, it's based on this relative value framework. And this is a framework that has largely been put in place and maintained by a certain group of medical professionals. So, this is part of kind of the delegated authority that the government has farmed out, if you will, to organized medicine, to groups that in turn organized medicine selects. And these groups, moreover, tend to have greater representation when it comes to certain specialties and certain specialists. And as a result, the relative value scale and the way that it compensates tends to favor highly specialized care and procedures, and pay handsomely for that, and tends to overlook, for instance, much in the way of primary care, consultation, ordinary consultation with patients. So the whole death panel debate was partly over a revision to this that would have allowed for greater compensation of physicians to simply have counseling sessions with their patients on their desires surrounding end-of-life care. Very innocent and indeed very needed. But this got twisted into, the entire death panel debate, became something unrecognizable, and as a result was left outside of the Affordable Care Act. So the Affordable Care Act and recent reform legislation has not had a lot to say in terms of, significant changes to the relative value payment system. Now we are seeing, there are beginning to be, again, experiments, pilot projects when it comes to, more prospective payment or payment based on quality or outcomes. So that's beginning to kind of take bites out of, this very much procedure-based formulation. But again, it's largely coming at the edges, and there's a lot of opposition to it within various parts of medicine. And so the extent to which, we're going to be turning away from either, the Medicare fee schedule or the relative value-based scale, I think is open to question. There are clearly some changes coming, but how truly revolutionary or transformative they are, I think is open to question.
Thank you.
Thank you. Great question.
Sort of fascinating. I was just invited today by the AMA and the American Geriatric Society to participate in revaluing nursing home services, which is
Interesting.
it's well super interesting since I don't do that work.
That may be a commentary on the system. I don't know
It may be.
itself.
Certainly, as a geriatrician, I have something to say.
Yes, yes,
And
absolutely.
we'll do so, but
And, it should be said that, organized medicine's stance has slowly changed with the times. I would say, during the 1940s and 50s, they presented the staunchest opposition to, changing the status quo, to, looking toward universal coverage, toward fighting, some of the inequities that we've been discussing. But that has begun to change, in recent decades. It hasn't been a complete 180. But there has been, cause for change. So we went from a point where during the 1990s, when you had the Clinton health reform debate, the AMA was still pretty much on the side of opposition. Once we got to the Affordable Care Act, they perhaps were not its strongest cheerleaders, but they didn't stand in the way effectively. And so, there has been a change. And part of that has had to do with a relative reduction in the clout of the AMA, as a rule. Of course, groups like the AMA, other, representative groups, groups representing other parts of medicine have multiplied. And the AMA has seen its membership, along with many, such groups, professional groups, unions, etc. It's seen its membership numbers decline significantly. And the people it's represented have changed, of course. In the middle part of the century, the AMA was largely representing independent practitioners, most of whom were, comfortable, well-off white guys. Increasingly, it is a more diverse body. And increasingly, we're not talking about independent practitioners. You're talking about salaried practitioners who, in many cases, work for hospital conglomerates. So it's a very different medical profession. And as a result, it's a very different professional organization.
were there any additional comments or questions from our students or fellows? Not sure if we have any nursing trainees or physician assistant students on.
Well, if any questions occur to people later, I know that I've attended many talks and, 5 minutes later, but like, oh, I should have asked that question. What was I thinking? If any occur to you, again, my name is Daniel Elke, E-H-L-K-E. I'm with the School of Public Health. I encourage you to email me, reach out to me. I'm happy to answer any questions, talk further about these significant issues. It's very much a passion of mine, and I'm always happy to discuss.
I will ask one more if no one else has any other
Thank
questions.
you. Thank you.
So I am just curious, in the next 2 years, if you anticipate there being political favorability for further changes into our system, one, and then generally there was the other speaker, I can't remember her name, who was a legislator, who said that we should get involved with advocating for what sounded like sort of parity or reimbursement for telepsych. How do we do that besides being involved with the APA and Brooklyn Psych Society? Are there other avenues? Thanks.
Great questions. Yeah. In terms of the next 2 years, quite frankly, I am not terribly optimistic in terms of any agenda for significant change. I do think what we're most likely to see is a buttressing of certain elements of the Affordable Care Act. So I think that, we're going to see, for instance, a rise in the subsidies available to help people purchase health insurance coverage. Those subsidies will be available to more people. And I think we're going to see an end to any efforts to repeal the ACA outside of the Supreme Court case that remains open as we speak. There's actually a Supreme Court case challenging the constitutionality, the existence of the entire ACA. It's unlikely to succeed, but we may not have a ruling for until, June, say. And until then, we won't be absolutely certain of the fate of the ACA. But I think that congressional efforts to repeal it are behind us. So we're going to move more in a direction of strengthening the Affordable Care Act. So incremental change, I think, is going to be the name of the game, not transformative change. So I don't think in the next 2 years, for instance, we're going to see any move toward Medicare for all, for instance. We may, see movement toward a public option potentially, but so far the indications are not great. Now, in terms of getting involved and of advocacy, I would say that, becoming an active member of these representative groups is one of the best ways to go, in terms of advocating. I would also, however, say that it is important to always remain on top of the latest developments, not only in terms of what legislation is being proposed, but also in terms of rule changes that may be on the horizon. So in my classes, for instance, I teach whole units on using the Federal Register, learning more about rulemaking and how it affects policy, because a lot of the issues that we're concerned with actually are not treated in, these large-scale legislative programs, but in terms of tweaks to existing rules. And the only way to find out about that very often is to go, for instance, to the Federal Register and to run a search or to look at it, from day to day and to see what's coming down at a given point. So I would say, part of being an effective advocate is really making, staying on top of what the policy climate is, both at the legislative level and when it comes to rulemaking, because a surprisingly large amount of policy change occurs in rulemaking. And it's an area of which relatively few people are aware at any significant level. And so it really gives you a leg up if you have a clear picture. And I see in the chat, we have a link. Thank you for that, to the Federal Register. There's also a state equivalent, a state register. So for state changes, rule changes that may be going into effect, it's good to check there as well. So I would recommend, just being aware of what's occurring, both in terms of legislation and in terms of rulemaking.
Let me just add a couple of things to that. And one you just alluded to, and that is we are seeing a lot of actions going on at the state level. As people may or may not be aware of, states regulate commercial insurance. You can't practice or sell insurance in a state, whether it's car insurance or health insurance, without going through the state regulatory body. So that's an important thing to keep in mind, because a lot of the changes that take place, they're on the margins, but they affect practice and the delivery of care, are taking place at the state level and are taking place through regulations as well as policy. There's a lot going on in the states around the country, and you can go to any state's website and find what pending legislation is. But one thing that I would suggest is that I find very helpful is to find out who your state legislators are and spend time talking with them, getting to know them. Because that's where you're going to have a lot of influence, as well as through professional organizations. There's also a number of patient care and consumer and public advocacy organizations out there. There's tons of them, and I'd be happy to respond to anybody who wanted some particular links. I could provide you with those. So I would find out who, both at the state and the federal level, who your legislators are. One thing for those of you who live in New York City and are in, particularly if you're, I don't know what district he is, I can't remember the number now, Senator Rivera, Gustavo Rivera, is incredibly engaged in healthcare. He chairs the Health Policy Committee in the state of New York. In the legislature, the assembly, and he also is co-chair of a regional public policy group. So he would be a great person to be in touch with as well. you know, we might want to, Michael, have a session on public advocacy, and get people hooked up with people, maybe even have Gustavo come and talk.
Yeah, you read my mind.
Yeah.
As you were talking, I was thinking this exact thing.
Yeah, he's really engaged. And in New York, the mayor's office and the bureau president also are very engaged in healthcare issues. So there's a lot of avenues we could talk about how to most effectively do that. But if you really want to make a difference in health and healthcare, you're really in a good position if you link up with your local folks, because that's the way you begin to have the most influence. Because they're concerned. Oh my God, these are all robocalls coming through. I'm sorry. So we can talk more about that again. I know we're at the time for our next session. So, but I'm passionate about all this stuff. So I'll be happy to chat.
Yeah, get to know your legislatures and get to know their legislators and get to know their staffs.
Yes,
Well,
yes,
absolutely.
yes.
Yeah.
Another particular area of concern for me, and because I always try to save more time for the trainees, and now we're over time, is
Yeah.
GME funding. It is absolutely abhorrent to me that we exist in a state of deficit
Okay.
regarding most primary care and mental health specialists, and have ready-made providers sort of sitting, waiting, and able to train throughout, particularly here in the New York region. But due to deficits in GME funding, are deficits in healthcare, health provider ability to meet healthcare needs are dramatically handicapped. And yet we continue to spend money on all sorts of things that I think most of us would rather our country did not spend money on. So thank you, Dr. Elke, for that excellent and invigorating talk. And thank you, everyone, for questions. And always, Dr. Gerard, thank you for your expertise and
Yes.
being an all-around all-star advocate for our older adult population. And so we're going to
Thank
switch.
you.
Thank you.
Right, we're on to the next
Thank you,
event.
Dr. Reinhardt. Thank you, Dr. Gerard. Thank you, Dr. Taylor. I appreciate it. Have a great rest of your day.